Hello, everybody. How's everybody doing? My name is Gaston Tesada. I'm the director here at the Oasis of Hope Hospital. To my left is our medical director,
Hi.
Dr. Paulina Larraga, and we'll be starting in about 2 to 3 minutes. Dr. Contreras is on his way right now. In the meantime, could you do me a favor? Why don't you give us a shout out, your name and where you're joining us from, because we have a very international audience. And we'll get started in a few minutes. We can just start trying to see if the chat is open, either the Q&A. I see last time I participated, Monica. No, we're going to go to, we'll get to your question. Okay, so we got Carla and Jose, Georgiana from Kaiser, Oregon. Hello there. Monica from Virginia. Robert from London. Great, amazing. Keep the names coming. Jeff from Texas. We have a lot of participants today. Mark from Los Angeles. Hans from San Diego. Welcome. Sharon from Florida. Amazing, amazing. Rachel from Arizona. And Jerry and Deb from Geneva, New York. Thank you so much for joining us today. It's a pleasure to be hosting today's webinar. Doug's from Louisiana, Ken from San Diego, amazing. We got somebody from Australia, great. Jose from Phoenix, welcome again, welcome. We'll be starting in a few minutes. Today's topic will be operable versus inoperable cancer. And Dr. Contreras will give a quick presentation on the subject, and we will then go into a Q&A where you can ask Dr. Contreras and Dr. Paulina all your questions, and we'll be happy to answer them. Dr. Contreras is here. So, Wilbur from Pennsylvania. This is great. Welcome, Dr. Contreras.
Hello, hello.
Well, I was just introducing the topic for today, Dr. Contreras.
Yes.
Today's topic will be on operable versus inoperable cancer tumors. And before we get started, Juliet from London. Look, very international audience. Amazing. We got people joining, continue joining. So I'm going to give just a quick intro. Once again, my name is Gaston Tesada. I'm the director here at the Oasis of Hope Hospital. Bear with us while we fix our cameras. And to my immediate left, we have Dr. Francisco Contreras, who is the surgical oncologist and medical director at the Oasis of Hope Hospital. And we have our medical coordinator, Dr. Paulina Larraga, who's in charge of patient care and the attending physicians here at Oasis. Oasis of Hope, as hope some of you know, but if not, it's been around for about 60 plus years, right?
Yes,
51 years.
Yeah.
Started with Dr. Ernesto Contreras, Dr. Contreras' father. So it's a legacy that we have here at Oasis. And we get patients from all over the world. And we run a cancer center. We have a hospital here also. And our treatments are integrative, meaning that they combine alternative and conventional treatments. If at any point you have any questions about our hospital, please feel free to ask the questions in our chat. I'm going to ask Dr. Contreras to begin his presentation, but in the meantime, we always have a lot of questions for the Q&A. We devote most of the time to Q&A. Getting to your questions and answering them is very important to us. So if you want to start asking your questions for Dr. Contreras and Dr. Larraga, please start so in the chat or in the Q&A section, and we will get to your question as soon as we can, after Dr. Contreras finishes his presentation. So thank you so much for joining us from all over the world. Dr. Contreras, take it away.
The term operable or inoperable is a little bit confusing because generally surgical oncologists will consider a case operable when the surgery's intent is curable. That is, a tumor is operable when we can remove it for the purpose of curing it. And inoperable is even more confusing because then the contrary would be right. If it's not the purpose of curability, then the patient is inoperable. But since the term inoperable means that you cannot operate, that is what is confusing, because there are some people that we can operate and remove tumor tissue for the purpose of improving their quality of life and not curing them. So when we use a term as surgical oncologists of curability, we call that an operable case, and the other ones are palliative. So there are palliative surgeries available for many, many patients, and there are curative procedures for patients that are in very early stages of the disease. And so it's always important to differentiate that. And usually that's a medical discussion, but a patient may hear the term, well, the doctor told me that I'm inoperable. Well, that doesn't mean that you cannot be operated. It means that you cannot be operated for curative purposes. So I hope this helps you understand a little bit more how we use the term. And it can be very confusing for the patient and even to many doctors if they are not surgical oncologists. Many terms have changed during time, during the time that was instituted, but still to date, we generally consider a early stage patient an operable patient, and inoperable when the purpose is when you cannot remove the tumor for curative purposes. So I hope that this helps you a little bit, and I think we're ready for the questions.
Amazing. Thank you, Dr. Contreras, for the quick presentation. I like it. Let's get to the Q&A, which is the most important part, because you can get to ask questions to Dr. Contreras about your diagnosis or just anything about cancer treatment in general at the Oasis or at home. So please feel free to begin asking your questions via the webinar chat or the Q&A, and we will start getting to them one by one. So I'm going to read them out, and Dr. Contreras and Dr. Larraga will be kind enough to answer them. The first question is from Aiden. My brother was recently diagnosed with stage 4 small bowel adenocarcinoma with peritoneal metastasis. He unfortunately has not yet had a laparoscopy performed. All we have to go on are PET CTs and MRI scans taken on 17th and 20th of January, which seem to show relatively stable disease when compared to his initial diagnostic scan on December 20th. PCI is obviously extremely important in this context if surgery is to ultimately be a possibility. In the absence of a laparoscopy, his PCI would appear to be 12 to 15 from my reading, which would certainly seem to be as hopeful as possible in this situation. Would you think there's a big margin for error here, i.e. relying on imaging rather than laparoscopy? If so, by how much would you estimate?
Well, PET scans are generally very reliable as far as the information that we get, and we can determine from the point of view of operability, we can definitely determine if the patient is operable or not. And if it's a stage 4, then by definition, it's not operable. Again, that does not mean that we cannot operate to improve the quality of life, for instance, to resolve the blockage issue. Now, if there is no diagnosis yet, except for the PET-CT, I would encourage a laparoscopic procedure to do a biopsy and then determine a diagnosis, whether this tumor is from the colon or from the stomach or from the peritoneum. It's a men, right? So
my brother, yeah.
It can be in many areas. So yes, a laparoscopic procedure would be a good procedure to determine the diagnosis. The spread of the disease can be determined by the PET, but not the origin or the type of tumor that the patient may have. Sometimes all we see is a tumor in the colon, and there are several types of tumors of the colon, so still we need to do a biopsy to determine what the proper diagnosis is in order to design the best therapy for that patient. So I hope that I understood the question correctly, and that that I answered it in a way that it's understandable to you. Do you think that that was?
Yes, I think
think
that was the question. Yes. I mean, in some cases can be a little bit of burden for the patients. Like uh, the doctor first requests to me a PET scan, then an MRI, but all of the imaging is not, they give us different details and we can have a better assessment of the case with different diagnoses,
Yes.
different imaging. Mhm.
Yeah, so the imaging, it helps a lot, but it does not give us a definite diagnosis.
Great. Quick question. Is it always the PET CT always recommended other than the MRI or just the PET?
Okay, so every study has a
benefit.
forte,
Okay.
and in general, for oncologists, the PET CT is the best study because it shows you size and tumor activity.
Okay.
But there are some malignancies where the PET is limited. For instance, there's a high percentage of false negatives in patients with prostate carcinomas.
Okay.
And so you have to use a different type of contrast material. But generally speaking, for cancer patients, the best is a PET. Sometimes, depending on what is it that you're looking for, you will use an X-ray, a CT, or an MRI. For instance, for most surgeries of the articulations and the bones, well, the MRI is a lot more precise than CTs. For soft tissue tumors, sometimes the MRI is a very good procedure, but then CTs have. So every study has
their benefits.
right.
But always PET CT is the first to start. Then you get another one.
Well, for cancer.
For cancer, yeah, exactly.
Yes.
Okay, got it.
For cancer. Sometimes you do others because it's expensive, or insurance companies will not pay for it. So there are other things to take into account.
Always.
But for us, for instance, we rely a lot on PET CTs to establish a baseline so that we can then determine the efficacy of the therapy in the future with another PET CT.
Perfect. Okay, so Amy is asking, can a patient be operated with an extrapulmonary small cell carcinoma, primary tumor on the tail of the pancreas, but liver has innumerous lesions, more than 90% on the liver?
So that is one of the cases where it's an inoperable cancer. Not because it couldn't be removed, but because it does not bring much benefit to the patient. So a tumor in the tail of the pancreas does not pose a blockage, or there's no reason to remove it to improve the quality of life of the patient. And since there's so much tumor activity in the liver, that patient requires a systemic therapy, such as ours, or in the conventional realm, chemotherapy.
Okay. Perfect. Continuing on, these are great questions, guys. Monica, do you have hormone treatments for breast cancer that has spread?
Yes, if the tumor is hormone dependent, definitely there are nowadays a good number of hormone blocking agents, depending on if the patient has received hormone therapy before, if the patient has ovaries or not, if the patient is menstruating or not. So there are many hormone blocking agents that are going to be offered for a patient with a hormone dependent tumor, depending on the things that I mentioned, whether they're menstruating, if they're not menstruating anymore, if they received a hormone therapy before that now it's not working. There are many options for a patient with a hormone-dependent tumor. In general, hormone-dependent tumors have better prognosis than hormone non-dependent tumors.
What's more common, hormone-dependent tumors
Yes,
or non?
those are the most common.
In breast cancer only or other?
Well, there's a few tumors that may be hormone-dependent, prostate, for instance. There are some ovarian cancers that are hormone-dependent. Very rarely, but you will find other types. But those are the ones that usually hormone therapy is going to be used to treat them. So the amount of tumors that are hormone dependent are the number is small.
Okay, number small. Okay, got it. Monica.
But in breast cancer, most breast cancers are
so the
hormone dependent.
breast cancer diagnosis, the next question is it hormone dependent or not?
Yes.
Got it. Perfect. Keep the questions coming, guys. These are great. Monica's asking, good afternoon. Last time I participated in the interactive Q&A, I explained to Dr. Contreras about my situation of not wanting to undergo traditional treatments for breast cancer diagnosis. I have no recent exams. In the interactive, Dr. Contreras gave me a lot of hope and I am willing to go to his clinic. I have sent emails and left messages. How do I speak directly with the doctor? Monica, why don't you put your email on the chat and I will email you after. We have an admissions office department with Mike and Jason. I don't know if you spoke to any of them, but usually, if not always, they speak to a patient, even if they're called or emailed, and they schedule a Zoom consultation with the doctor. But if you have no recent exams, we would need your original pathology report and any medical notes that you might have.
Yes. So what I'm understanding is that she contacted us and we did not.
Either they contacted us and we didn't get back to them, or because there's no recent exams, we couldn't do the Zoom call.
So please just contact us again, and we'll by tomorrow we'll answer you.
Yeah, Monica, or our admissions department is actually open right now. You can reach them at 619. It's a U.S. number, 619-690-8450. That's 619-690-8450, and we'll be happy to get back to you on that. Hans, what are your recommendations for the treatment of triple-negative breast cancer?
Okay, so that's one of the tumors that are not hormone dependent that we're talking about. They're usually they usually appear in younger women, and they are usually quite aggressive. Fortunately, our therapy has proven to be very effective in triple-negative cancers. So if you want to contact us, I will send you very specific recommendations for your case. But we have been fortunate to help many patients with advanced triple-negative carcinomas. Even if it's in an early stage, well, even better.
Okay. Yeah, we get a lot of patients for triple-negative breast cancer calling us. So yeah, Hans, please feel free to give us a call or email us, or go on our website and fill out one of our contact forms, and one of our admissions officers will get to you quickly. Thank you so much. Karen, my recent scans showed disease progression, 5 to 6 new lesions on my solitary kidney and 1 lesion on my right flank. Is my situation operable at this point? I have ccRCC.
Okay, so renal cell carcinomas obviously was your original diagnosis, and I'm assuming from the information that you told us that you had that removed, and so you were operable at that time, or it was an early stage. Though still in the old school of surgical oncologies stated that a renal cell carcinoma, even in advanced cases, should be removed. The kidney should be removed, because by removing the mother tumor, the metastasis would suffer. That is debatable nowadays. There's a lot more information, but the fact is that you had a kidney removed, and now you have a recurrence in the other kidney. So obviously you are not a candidate for surgery, because then you would have no kidneys and you would have to go into dialysis. And I'm assuming that there are tumors elsewhere. So a treatment like ours would be a good option for you, because renal cell carcinomas only respond partially or temporarily to conventional therapies. In fact, today I saw a patient that came with renal cell carcinoma that was told that he was going to die in a few months, and it's been 2 years. He's doing quite well. The tumor's still there. He's very stable, quality of life perfect. I believe that a treatment like ours would be a good option for you. But surgery, I doubt that it's a good option for you.
Great, great. Thank you, Karen. Thank you for your question. I think she has a follow-up question. Should I have a pet even though they are not standard protocol for ICC?
Yes, because that would let us know if there are if there is tumor activity elsewhere, lymph nodes, lungs. The lungs are usually the target area for metastases of renal cell carcinoma, and we can see those very well with the PET scan.
Perfect. And she's also says that she's scheduled for an MRI in a week.
Yes, any imaging is going to help us determine what the status of your case is presently, so that we can design the best therapy for you.
Great, great. Thank you so much. Trisha is asking, I have a family member that has stage 4 cancer in her jawbone. It has formed a large tumor that has taken over the point that her face is disfigured and her teeth are falling out. She also emits a very strong odor from her mouth. She is 82 and has put off getting surgery to remove it. Do you know if she is still a candidate for surgery or is it too late?
It seems to me that it's a little bit complicated to operate on an 82-year-old lady. We would have to determine first if her heart is okay, if her condition would allow for such a big surgery. There are other options. I'm assuming that this tumor is most likely a sarcoma, right? A bone sarcoma. If that is the only area that is affected, primary tumors of the bone are very rare, unless this is a metastasis or it's an invasion from the squamous cell carcinomas of the head and neck, which are very, very common. But at 82, the surgical limitations can be quite high if the patient has any sort of heart failure, renal failure, liver failure. No matter how mild, it can preclude her from being a candidate. If you send us more information about her case, we can then definitely study it and send you a recommendation.
Thank you, thank you. Continuing on, let's see.
Yeah, probably I think that also the anesthesia, because of the intubation, it will be challenging. So
Yes,
I think
yes.
that there's a lot of factors to consider there.
Correct. So surgery would be very difficult in a patient like that.
Okay, Rachel is asking, I am stage 2 invasive ductal carcinoma. I don't want to go through chemo due to side effects. Prefer lumpectomy or mastectomy. How do I know if it's operable for cure versus going through chemo? Thank you.
In stage 2, stage 3 breast carcinomas, we do, or in the conventional realm, neoadjuvant therapy is done. And the purpose of the neoadjuvant therapy is to reduce the stage from 2 to 1, from 3 to 2 or 1. And so you use chemotherapy to do that because stage 1 offers you the highest rate of cure. But this is recent, I would say maybe in the last 15, 20 years maximum. And before stage 2, we would do a lumpectomy in most cases, depending on the location of the tumor in the breast, or sometimes mastectomy, and the curability is quite high. And then we can offer you a treatment like ours to reduce the risk of recurrence. So stage 1 has the lowest risk of recurrence. Stage 2 has a medium risk of recurrence. Stage 3 has a high risk of recurrence. So in stage 2, and I hope that you have a PET-CT or something to corroborate the stage. But yes, you are definitely a candidate for surgery, and chemotherapy is not absolutely required in order for you to have the surgery.
Also, I think that one of the advantages in breast cancer surgery is that we diminish the percentage of recurrence, because of patients that doesn't have surgery after chemo or another type of treatment, and they don't remove it, like this scar tissue can tend to cause recurrence, right?
Correct.
And if we remove the tumor, then it's a
Yes.
lower risk of
Yes.
recurrence.
Really, it's a lower risk of spreading of the cancer.
Mhm.
So the larger the tumor is, the faster it can go to other
Mhm.
places in your body.
Detach from the.
So overall, a lumpectomy in stage 1 has a recurrence rate of between around 18%.
Okay.
Stage 1 is when the tumor is 2 centimeters or less, and there are no lymph nodes whatsoever. A tumor that is more than 2 centimeters and has no metastases to the lymph nodes, that's a stage 2, up to 5 centimeters. And then there, the risk of recurrence is about 35%. That's why neoadjuvant therapy is done, so that if you reduce that to 2 or less, well, then the recurrence rate would be around 18%, and so on and so forth. We can reduce without chemotherapy, with our therapy, that risk of recurrence that
Yeah.
in her case, that is stage 2, would be around 30%. And so that's what we would work on and avoid the chemotherapy altogether, and radiation as well. And we have been very, very successful in doing that.
Perfect. Moving on. Thank you for your questions again. These are great questions. And Kenlin is asking, do you have any success in treating stage 4 TNBC?
So it's triple negative
Negative
breast
breast
cancer. Yes, as I mentioned before, maybe you were not there. We have been very successful in helping patients with even, she said stage 4, right? Yes.
Stage 4, yeah.
Yeah, in advanced cases of triple negative breast carcinoma. The patients that come first to us without any treatment before have better outcomes. But even if you had chemotherapy already, our results are very, very encouraging.
Perfect. I don't know the acronym. I didn't know the acronym for triple negative breast cancer. Will not forget, I promise. Jose is asking, clinical prognostic stage IB. Lot of numbers there. It's a stage 1B, right? Stage 1B. ER, PR, HER2 positive. So hormone positive. Yeah. This is a 42-year-old female with new diagnosis on right breast. ILC.
So let me just talk a little bit. Triple negative is one of the cases where the prognosis is dire. Okay, so it's a lot more aggressive, and we think that triple positive then would be the contrary. The best prognosis is hormone positive, HER2 negative. Okay, that is the tumors with the best prognostic factors. HER2 have a little bit less, or they're a little bit more aggressive, but on the other hand, it opens the door to HER2 inhibitor therapies, which are readily available and are quite effective. So there's a little bit of confusion there, but still, you have good prognostic factors. The KI was not mentioned, right? Okay.
No.
So, and it's a 2B. So again, you would be
I think it's 1B.
1B. Yeah. 1B.
Wow, you are in a curable stage. My proposition in your case would be to do a lumpectomy. Again, depending on where the tumor is located.
Right breast.
Yeah, but where in the breast?
ILC, does that mean anything to you
I
guys?
think imperial left quadrant, lower quadrant.
Yes.
Okay.
Yeah, it's not the ideal place for surgery, but if there are no lymph nodes, a lumpectomy would be a good option for you.
Perfect. Thank you, Jose, for your question. I think Kemlin is asking about triple negative, but we've been through that. There's a follow-up question from Aiden, who was asking about stage 4 small bowel adenocarcinoma. And he says, thank you for your response, doctor. I don't know if it is possible for me to follow up, but the main tumor is located in the jejunum. Jejunum?
Jejunum.
Jejunum. In itself, it apparently would be resectable if it had not metastasized, but first-line surgery has been ruled out, and now he's undergoing FOLFOX. So we are more concerned about the peritoneal metastasis and whether it's accurate, even relatively accurate, to estimate PCI from imaging alone. in the absence of a laparoscopy, just to keep hope of surgery beyond his initial treatment?
Yes, as I mentioned before, if now we know that you were diagnosed already, so we know the origin of the tumor, which is in the small intestine. It is not operable, and FOLFOX is one of the most common combination of chemotherapies that have proven to be somewhat effective, but they're only partially or temporarily effective. Once you obtain or achieve the maximum benefit from that therapy, up to complete remission, I would urge you to come because our protocol has proven to be very effective in these type of tumors. So if the chemotherapy, let's say that it reduced the tumor load by 50%, by 90 or 100%, the possibility of recurrence is very high. So our treatment would consolidate the results, enhance the results, and reduce the risk of recurrence significantly.
Perfect. Let me see. We're getting a lot of follow-up questions. So, I think Tricia, it is also in her lymph nodes. I mean, first, Jose asking about the stage 1B. The HER2 positive is asking, they're telling us to start chemo immediately for 6 months, then surgery.
No, forget about the neoadjuvant therapy is with chemotherapy, and chemotherapy is immune suppressive, very aggressive, and for a 1B, I don't think that it's necessary. I think that a lumpectomy should be done as soon as possible, and your possibility of cure is quite high. And the protection with our therapy would be better.
Something that I have heard from you that I think that is also important is that not always, even though the patient is candidate for lumpectomy, depending on the breast size, in some cases, cosmetically will maybe not be the proper surgery, right?
Correct. So we take all of those things into account, but in a very early stage like 1B, where the possibility of cure is so high, and it means that the tumor is 2 centimeters or less, I would say that a lumpectomy is going to be a good option.
There's a follow-up question from Monica, and she's asking, I don't want chemo, but neither surgery to remove my breast. Do I have options? She had put before that, do you do hormone treatments for breast cancer that has spread? So, yeah, so breast primary.
Okay, so it has spread already.
It has spread already.
So
yeah.
surgery is not a good option. Chemotherapy is not necessarily the best option. And therapy like ours would be you would be a very good candidate for our therapy. I would urge you to look on the website and see our results. Our 5-year survival rates in stage 4, as yours is, are very, very good. Much, much better than with conventional therapy. And so you can find that information on our website.
Perfect. I think there's a lot of follow-up questions this webinar, which is great because we can get to all your questions and you can have a chance to respond. Amy is asking, thank you for kindly answering my questions. What are you able to say about your Oasis of Hope treatments of liver metastasis from his pancreas tumor? With his liver having numerous lesions, my husband has had 1 round of chemo and as he was given 3 months to live. Should we stop the chemo and try your treatments better for chances of survival? So it's liver metastasis
from the pancreas.
Yeah.
So pancreas carcinoma with liver metastasis is one of the most aggressive. Chemotherapy is of very little use. It's only going to deteriorate the quality of life that he has. And I would urge you to consider our therapy. Miracles happen. Our therapy is going to, for sure, improve the quality of life, not deteriorate the quality of life. And God willing, your husband may respond to the therapy. It will depend on how damaged the liver is, because if your husband already has liver insufficiency, then we cannot administer our therapy. So we would be very limited. So if you send us your lab reports, liver function tests, we would evaluate your husband's case, and we will let you know if he's a good candidate or not. But definitely chemotherapy is of very little value. It's only going to deteriorate him, and I would stop it.
Okay.
With liver metastasis, I think that we have advantages and disadvantages. When it's severely affected, then because the liver metabolizes everything, food, supplements, treatment, we cannot do much. But even though it is affected and still working, then everything passes through the liver. So normally the therapy reaches very well, and normally the liver can be one of the organs that first respond to the treatment.
Okay.
Correct.
So yeah.
That's a very good observation. So you may have massive liver metastases with very good liver function. If you have good liver function, then the liver will metabolize, will activate or deactivate everything that you consume. And it's the first organ that would respond if there's going to be a response.
I didn't know that. Even if you have liver metastasis, you can still have a well-functioning liver.
Perfect.
Even with tumors in the liver.
God gave us so much liver because it's so important. But with 10% of your liver mass, all the needs of the body are provided.
So when
So
there's
you
a
may
liver,
have 90% of the liver involved and still have good liver function.
so when there's a liver transplant, they just take a piece of the tumor? Or
No, a liver transplant generally,
yeah.
they remove the whole.
Okay.
They replace
There
it.
are
They're
you-
partial liver transplant?
Yeah, well, what happens is they remove the old liver completely, and then they can partially, they can do a partial transplant of the liver.
Huh?
So a donor can donate, let's say, half of the liver to a patient. It's complicated, but it can be done.
I've been working here for 16 years and I still learn something new every day here at the hospital. That's true, that's for sure. Thank you so much for that question. Continuing on, Jose is asking about success rates. I think Jose is the stage 1B, right? Stage 1B, the HER2 positive. Success rates, and are you available for evaluation consultation? I'll let Dr. Contreras answer the success rates, but yes, Jose, contact us, go to our website, fill out one of our contact forms, and we'll set you up with a free Zoom consultation with one of our doctors. And we can do that pretty quickly if you have your medical records on hand. So he's talking about success rates for stage 1B. I mean, for early stage.
Early stage, we do not have, we're only eligible to do stage 4 prospective clinical trials. And in stage 4 patients that have received chemotherapy, radiation, hormone therapy, any type of therapy before, our survival rate is 3 times higher than with conventional, and it's around 50%. When a patient comes to us virgin to treatment without any chemotherapy or hormone therapy before,
Even in stage 4. In stage 4, yeah.
The studies were done only on stage 4. The survival rate is 75%. So our treatment has room to be very effective. So you can extrapolate that to lower stages, and our results have been very, very good. Now, you mentioned 2.5 centimeters. So 2.5 centimeters, by definition, is stage 2. I'm not sure why they're calling it 1B. So 1 is when the tumor is up to 2 centimeters in size. Regardless of that, I think he's talking about his wife or sister. The surgery is a good possibility for her.
Perfect, perfect. I think Rachel's asking a follow-up question. Let me see if I can find it. I don't remember reading it from here. It wasn't another email over here. Answer Rachel. Let me just check.
I think I saw it.
You saw it up there?
Yeah.
I'm sorry, just bear with it. Rachel, oh yeah, Rachel says, I'm coming, can't wait, just recovering from surgery, back, but I can't wait to be there. Okay, Monica, that's a good choice. Thank you so much. That's Monica Sanchez. But Rachel says, what is your recommendation for me? Chemo with surgery or lupectomy or mastectomy without surgery, but Did you see
Yeah,
her
I
original
saw it.
question?
So again, if
There.
you,
Rachel, here we go. Stage 2 invasive ductal carcinoma.
I think surgery would be a good option for you, and we can avoid the chemo and the radiation by doing our therapy. And she was hormone dependent, right?
I don't
Oh,
recall.
hold on.
Mm,
I think she had good prognostic
There we go.
factors.
Stage 2 invasive ductal carcinoma. Don't want to go
Okay,
through.
so let's find out
We
in
don't
the
know.
original pathology report.
Uh-huh.
They will tell you if your tumor is hormone dependent or not, if it's triple negative. All of those things are important to determine. But you would definitely be a good candidate for surgery, and
Okay.
hopefully is just a lumpectomy if it's stage 2 especially.
Got it. Rachel, don't be, contact us. Contact us. So we're here for you. So Jose is asking a follow-up question. Confusing because it prognosed as 1B, but the tumor is 2.5, HER2 positive 3.
probably 3
So
plus.
yeah, it's
Yeah,
probably
3 plus. It's
3 plus.
very positive to her too, and most likely hormone dependent. So yes, I don't know why they staged it at 1B, because by definition, more than 2 is already stage 2. In spite of that, it's a good size and a good prognostic factor.
All right. Okay. Karen, this is a very detailed question, so bear with me. Karen is asking, what are your thoughts on combining conventional immunotherapy with personalized immunotherapy as offered at Oasis? Do you have any experience with renal cell carcinoma patients that have done conventional immunotherapy in the U.S. and then come to Oasis for dendritic cell therapy? If not, have you followed in the current clinical trials in the U.S. that is combining these two strategies for RCC patients?
Yes, and they can be combined and it can be synergistic. We don't do it very much here because the conventional targeted immunotherapies like Keytruda are very, very expensive. And so in our environment, they're not usually administered because of that limitation. It's usually around $10,000 every 3 weeks. But if you can continue with the targeted immunotherapy at home, like Keytruda, and combine it with our therapy is a very good combination because the mode of action of both of them are different, and they can synergize. So the immunotherapy, conventional immunotherapy, are called checkpoint inhibitors. And so what this does is that it just frees up the immune system to attack without any regulation. But that is a very broad spectrum type of immune attack, where our therapy is extremely specific. So we create a cell therapy, a dendritic cell-based immunotherapy that is very personalized. It can only be given to the patient that we are preparing it for, and it's only effective against that patient's tumor. So the combination is a broad spectrum immune attack with a very like a sniper attack to the tumor with our therapy. And yes, we have combined that whenever it's possible for the patient, and it's a good idea.
Yes. Tell them the new name of the therapy.
Pardon me?
Tell them the new name of the therapy.
Impact.
Impact.
The IM is for immune, P for personalized, A for autologous because it's made from your own tissue, cell therapy.
I like it.
Impact.
Yes.
It's a good name.
Yeah.
Right?
It's a great name.
Yeah.
It's a great name. Thank you so much,
I
Karen.
wish that I had come up with it, but it was AI.
AI gave us a lot of.
That was good.
We
I
had a
really
couple.
liked
We had a
it.
couple. We had a couple.
Yeah.
Yeah, we were close. We were
Yes.
close.
It was
Right.
the autologous. It was the
Right.
autologous that
Yeah.
gave us a
Yeah.
difference. We were like, but
Right.
if it's from the patient, it's from the autologous, and when we put that in, it gave us a lot of
Yeah.
other options. So, did
Yeah.
you want to add something?
Yes.
Yeah.
Just to add, one of the difference between conventional immunotherapy and autologous immunotherapy, that's what we give to the patients, is that we don't have the secondary effects like autoimmune diseases that can be developed by conventional immunotherapy. So combining, it's very good, but we don't add those side effects that we can expect from this conventional therapy. So it's good.
Yes, yes. It's a very, very good point where the conventional targeted therapies may have some very severe side effects. Ours do not.
Did Keytruda have side effects or?
It can.
can?
It's generally well tolerated, but
Yeah.
all immunotherapies can eventually, not necessarily, but can eventually lead to autoimmune diseases.
Yeah.
But we have a patient right now that had Keytruda for 4 years.
It was amazing.
I've never heard of that
Yeah.
ever, and no autoimmune
autoimmune.
diseases, and doing quite well.
Yeah.
So even though there may be some side effects in renal cell, which is very aggressive, I would encourage you to do the the combination therapies. So even if in the future we have to deal with the autoimmune disease, at least it gave us sign, and there's a number of things that we can do against autoimmune diseases. So if you have to pay to cure your cancer with an autoimmune disease, we can do much for you as far as
it's a good payoff.
it's
It's a
yes,
good payoff.
it's a good trade.
Yes. What are the typical autoimmune diseases that stem from immunotherapy?
I think one of the most common is arthritic problems.
Okay.
Yeah.
Okay.
But there are many.
There are
It can be
many.
lupus. It can be any
ALS, MS, or that
MS,
more?
ALS is not autoimmune,
No.
right?
No, ALS.
ALS is not autoimmune, but MS is.
Okay.
Or we
ALS
can
is more
have
chronic disease.
Yes.
Okay. I'm sorry, you were saying.
yes, or we can have modulated immune responses, like for example, diarrhea can be caused by the immune system, not
Right.
exactly an autoimmune disease,
Okay.
but can be caused
Right.
by.
It cannot. It does not necessarily be a permanent
Okay, got
problem.
it. Okay, got it.
It can be a reversible problem.
Right.
But I believe that the dendritic cell therapy would protect
Can
that patient a
diminish,
lot,
right?
because you can even use dendritic cells to treat autoimmune disease.
Yes,
Exactly.
yes.
Which we're exploring now.
Yeah. Yes.
And all right, Karen, that's a great question, Karen. Led to a lot of different themes. Leticia, I have stage 4. Is it what is MCB?
MCB with
is
bone and bone.
metaplastic carcinoma?
No.
No,
What is
with bone
MCB? Can you please?
metaplastic. It's not
Yeah.
metaplastic carcinoma of the breast, medular carcinoma of the breast,
Oh, it could be
medullary.
medullary, which is not common at all. But it usually would be MBC.
MCB.
But it's MCB, huh?
MBC, multiple breast carcinoma, multiple
Metastatic carcinoma of the breast. I'm not sure. Please let us know what you mean by MCB.
But we'll continue. And my PET scan has showed increased activity in the current tumors, but no new lesions. However, one of my tumors on the head of the femur is compressing my hip and have high potential of fracture. Thus, I was cleared for radiation. I am BRCA2.
Okay, so it is breast cancer.
And HER2 positive and PIK3. Is that PIK3 or PIK?
PIK3.
And severe and allergy to chemotherapy, and HER2 side effects was severe burning sensation with sores in the mouth. Further, I have had several blood infusions because I'm severely anemic. What treatment options are available to minimize toxicity or help me control the progression?
So the first thing is that you need the radiation to the hip, because radiation is going to bring down the inflammation and it's going to harden the bone and reduce the risk of fracture, which is one of the main problems that can happen in your case. And usually the amount of radiation given is low, so you have very little to worry about. Once that is done, I think that a treatment like ours would be a very good option for you. And I'm not sure if you already had anti-HER2 targeted therapies like Perjeta, like Herceptin. There are a number of them now, and I think that you could be a good candidate for that. In HER, well, no, she
In
is having an
HER2.
HER2.
Yeah.
Mhm.
So Enhertu is an anti-HER2 medication. I think you're a good candidate for that. It's generally well tolerated. Perjeta, Herceptin, probably better, but maybe you already had those, and that's why you are taking Enhertu. And combination of that with our therapy would be very, very good. That you are one of the typical cases of our prospective clinical trial with stage 4 carcinomas. And as I mentioned before, our results, the 5-year survival rate is 3 times better than with just conventional therapy.
Okay. Let's see, that was good. Rise Semela. My husband has prostate cancer and did a prostatectomy and radiation, but is coming back in the prostate bed and 1 or 2 lymph nodes. Will your therapy help him long term, or is it just short-term help?
Definitely, and it can be for a very, very long time. And so if the recurrence is just localized to the area where the prostate was, the possibility of help with our therapy could be very, very good. And depending on the Gleason score that he had, which goes from 6 to 10, most likely we will recommend some hormone blocking agent.
Perfect, perfect. Moving on. See. M. Sarna is asking, I have a tonsil tumor, stage 3 metastasis to lymph nodes. Oncologist said it was not operable. What are your thoughts?
We've had very good success against squamous cell carcinomas of the head and neck, be it from the tongue, from the tonsil. It doesn't matter. Our results have been very, very encouraging. If there is a lymph node that is easy to remove, I would encourage you to come and we can remove that lymph node and use that tissue to prepare the vaccine. There are some advantages when we use fresh tumor tissue to prepare the immune therapy. I would encourage you to come.
Okay, great. Thank you, Dr. Contreras. Jennifer Orr, I don't know why that name sounds familiar. I think you've been one of our webinars before. NSCLC, squamous cell carcinoma, stage 4. Tumor measuring 3 times 3 by 5 centimeters in the lung that has spread to T4, T5 of the spine. Doctor recommending more chemo, which would only be palliative, but I don't want to destroy my immune system.
Yes, non-small cell lung carcinoma is the less aggressive of the two, but it's still quite aggressive. And the results with chemotherapy are very discouraging, and chemotherapy is devastating. I would ask you to consider our therapy instead of that. I think your chances with our therapy are much better than with conventional therapy. We did a prospective clinical trial with that, and our results were much, much better, 9 times better. Now, this is a little bit confusing, so I want to reiterate those results. The 5-year survival with this type of tumor is virtually 0.
Mhm.
Most patients will die within the first year of diagnosis. And so when you combine all of the literature out there, the 5-year survival rate is about 1%. Our 5-year survival rate is 9%.
9 times.
So it's 9 times better, but these are very aggressive tumors. But we have a number of patients that have done very well for many, many years, but they're not cured. Okay, so the tumor is not completely gone, but they couldn't care less if 10 years later you take an X-ray and the tumor is still there, but the quality of life is perfect. So the possibilities are good.
It always reminds me of you say this sometimes, but it's a successful failure. Successful failure.
Well,
you didn't get rid of the tumor, but the patient's alive.
Yes.
Correct,
Yeah.
correct, because many times what they measure is what happens to the tumor. So the chemotherapy can be very effective in getting rid of the tumor, but then the patient's dead.
Exactly.
And still the patient goes into the books as a success. So that
So it's a failed success.
it's a dead success.
It's a dead success, yeah.
Right. So I'd rather have live failures, and that is patients like ours where we treat them, they're alive for many years, but the tumor is still there. So as far as the tumor is concerned, the patient is a failure, but the patient is alive.
Yeah.
And so I think that's much better
Yeah,
than
for
going
sure.
to 3 feet under without any tumor activity.
Yeah,
Not able to enjoy life.
Yes.
exactly. You asked a couple more questions, Jennifer, but I think Dr. Contreras got to them. Is the dendritic cell therapy an option?
Yes,
it is an option.
it's a
If
very good
we're-
option.
Yeah. Received targeted treatments, chemo. I think you went through that. Also, okay. Karen Booker, love it. Thank you. Love you back, Karen. Thank you so much. Monica Amayo. Oh, wait, thank you for sending us your email, Monica. I'll send that to. I received an email from Jason 1 month ago telling me without a recent test, you can now schedule a meeting with Dr. Contreras. I sent an email, but I haven't heard anything in response. I will call again. Monica, I'll make sure that we reach out to you today and schedule a consultation with one of our doctors.
So when was the last time you had an evaluation of your tumor, Monica, if you can tell us that? But send whatever information you have, and
Yes.
we'll let you know what we need.
Got it.
But I think Jason probably saw that the test was maybe a year old, and so we needed to know.
Yeah, and the reason that happens is that if we don't recent test, we cannot give
Correct.
the best recommendation. So sometimes we do require the most recent PET CTs or lab work because if we don't have recent recommendation when the patient gets here,
Yeah,
it's
then we're gonna give you the
completely
wrong
recommendation.
recommendation.
Exactly. All right, Monica, but do contact us. Emsona, thank you for answering my question. 10-year survivor, that's Jennifer Orr from the
Oh, no wonder, yeah.
10-year survivor, yeah.
Of non-small cell carcinoma. Wow.
Yeah.
So
Congratulations.
exactly, she's a patient of what we were talking about.
Yeah.
That most likely, and I hope that Jennifer is without any evidence of disease, but if there is of no concern.
Great. Wilbur is asking, what treatment would you recommend for stage 2 follicular lymphoma? Several spots in my abdomen and one near my collarbone and one that is pressing on my windpipe. Is immunotherapy a good treatment choice? Would you have something better that you could recommend?
In your case, conventional therapy with chemo is extremely effective. And so in cases like yours, we recommend conventional therapy because the cure rate is about 95%, 92 to 95%. And so there, the benefit outweighs all of the risks. And so send us the information just to make sure, because if you have involvement above and below the diaphragm, you're not stage 2. But it doesn't matter because the chemotherapy, even in very advanced cases, stage 4, is very, very effective. As I mentioned, about 92, 93% cure rate. Now once you're done, I would encourage you to come because our therapy can repair the damages caused by the chemotherapy. Other patients come to prepare themselves for the chemo. And so we do what is called a preconditioning. And that way the patient goes into the chemotherapy in a much better way. And the side effects and the permanent damages that chemotherapy can cause are diminished significantly. And so that way we can combine the therapy, but the chemotherapy is very effective.
I think that some of the patients, when they are like with no evidence of disease, they see the lack of benefit of coming to have immunotherapy. But this is like a more long-term treatment because we are teaching your immune system that there was a threat, how is it, and to be on top of it. So
yes,
that can diminish and lower the rate of recurrence. So
yeah. So what does it mean that 93% chance of cure? That 7% to 8% chances of the tumor coming back.
Okay.
And with immunotherapy, we diminish that 7% even more. Most tumors have a much higher rate of recurrence. And so we can impact that.
With the impact therapy.
With the impact therapy.
Impact with impact. Double impact.
Right. I love it.
So the great thing about the immunotherapy is that it kind of trains your immune system to react,
Yes.
right? And it stays
Yes.
off the
That's why
yeah.
they called it a vaccine, even though it's not
Yes.
truly a vaccine.
You can't say vaccine on
And on top of
We
it,
will
on
avoid
top
that
of it
word.
now, we're getting canceled. So hopefully with Bobby Kennedy, that will change a
Yes,
little
yeah,
bit.
we'll edit this part out, yeah. Just kidding, just kidding. You see, Jose Gonzalez, I think it's the one that was 1B, but it's really like stage 2 breast cancer. Would you do lumpectomy, then chemo, or reverse? I think it's lumpectomy first, right? Then chemo.
Lumpectomy
Yeah.
first, and
Surgery
then do our
first.
therapy, usually without chemotherapy, because it was hormone dependent, right?
Yes, was for
Young, I'm assuming.
I think
young.
it's 43,
42.
40, yeah,
Yeah.
42, 43.
Yeah, so
Yeah.
still menstruating.
Yes.
We might do some hormone therapy to reduce the risk, but no chemo or radiation.
This is a very interesting webinar. We're getting a lot of follow-up to the
Yeah.
questions, which usually
Yeah.
we just go from question to question, which is amazing because we can actually answer the complete question and
Yeah.
get back to the patient. More like a little consultation. Hans is saying, thank you so much for this great information. Unfortunately, I have to run to another Zoom. But okay, that's fine. But you will stay here until almost 5 o'clock. It is 5.
It is
So
fine.
Flew by. So you do a couple of questions.
It went-
Contreras, he gets always fly by.
Yes.
It went fast.
When it's like 4:15, I'm like, oh my God, 45 minutes up. But then the questions start coming. Angela's asking if you already have autoimmune disease, checkpoint inhibitors exacerbate immune.
It can,
Yeah,
it can,
Does it
yes.
exacerbate?
So it's one of the criteria of exclusion. So
Yeah,
you
okay.
might not be a candidate for
Clinical trials?
But again, if the oncologist believes that the benefit outweighs the risk, they may give it to you because you already have immune system and an autoimmune disease, and so this is not going to make. Hopefully, it will not make it worse. I would have to check the literature on that.
Okay.
If it exacerbates an autoimmune disease, I would tend to believe that it would.
Yes, but not sure how much the percentage.
Right.
Not sure.
But again, cancer overrides everything, and if it helps to
Yeah.
diminish the tumor activity, I would be open to it.
I think she was excluded because it happened to me. So I think she was excluded from the clinical
Okay,
trials.
yes.
Yeah.
Yes.
Can you take the dendritic cell therapy home with you? We wish you could. We wish you could, but no, the dendritic cell therapy is done at the hospital. Takes about, to prepare the cell therapy, about 6 to 8, 7 days, right? 6 to 8 days, depending on the type of.
Depending on the
therapy.
type
I'm
of-
gonna go into
Yes.
that, Dr.
And you cannot travel with it.
You cannot travel with it.
Yeah, and also remember that are live cells.
Yeah.
That normally they survive in your environment. We try in the lab, of course, to do the proper environment for them to live, to duplicate, to cultivate. But yeah, you cannot travel because they will die.
They will
are
die.
live cells.
Okay, Jose, you send me your email. I'll send that to the admissions department, but you can go to our website and fill out one of our contact forms or call us. We have admissions officers right now, coordinators on the phones right now. If you want to call us at 619-690-8450, that's 619-690-8450, or email us at info@oasisofhope.com. Two more questions. I know. Let me see. We do stage 4 esophageal. Okay, so Tara's asking, what would be your usual approach to stage 4 esophageal cancer? 75% blockage of the esophagus that has spread to the liver.
So generally, in your case, we are going to offer what is called our metabolic therapy and then the impact together with very good results. But we have to resolve the issue of your food passage. At 75%, I think you're still eligible for a stent, and that would help tremendously so that you can continue eating. Because if not, a G-tube, what's called a gastric tube, has to be installed because then you will not be able to eat. And all therapies are going to cause some inflammation. So for a while, that 25% opening that you have is going to be restricted, whether you use therapies like ours or conventional therapies. So in many cases, a G-tube is installed to protect you so that you can continue eating while you're on the therapy. This is a temporary thing. As soon as you have results and the tumor diminishes in size and your esophagus opens, then the G-tube can be removed.
Okay.
Now, one of the good things I believe that of the things that we have changed along the way of the home treatment plan is that now we have a lot of liposomal. So for patients that have some partial obstruction, they can still take the home treatment plan and still can maintain the good benefit from the treatment here. So
that's a very good point. With 25% opening, most pills would not go through, and so before the nano particle products, all of the therapy was in the form of pills or capsules. And so the advantage now is that most of the therapy is in liquid form. And so even though you have this stricture, you could continue with that therapy. But it needs to be resolved so that you can eat.
All right. So last question is going to be from Georgiana, but before Amy is saying thank you so much.
Let me just finish by esophageal carcinomas. They're going to offer you very harsh chemotherapy like FOLFOX, FOLFIRI, or sometimes FOLFIRINOX. They're very aggressive. The response is very poor. And so even though there's liver metastases, the possibilities of response are better with our therapy than with conventional therapy. It's a very complicated type of tumor. It's a very aggressive type of tumor, but chemotherapy is of very little value to you.
Okay, Georgiana, our last question, and could be the best question. You never know. Ovarian cancer 4B, so stage 4B. Functional treatment with anti-parasitic, then chemo, debulking, more chemo, another cycle of anti-parasitics, ivermectin, etc. And now maintenance for almost a year with Zeribev. Would this dendritic therapy you speak of be warranted to inhibit recurrence, and is it a residency type therapy or coming for a day or two?
You would be a very good candidate for our impact therapy. You've done well. I think that everything that you did was perfect. And so in order to reduce the risk of recurrence, our impact therapy would be very, very good for you. You would have to come at least for, what is it, a week?
A week, at least a week.
So that we prepare the vaccine and then give it to you. Yes, you would be a very good candidate for our therapy.
Do you want to explain a little bit to the audience how the treatment works? I mean, the dendritic cell therapy is usually reserved for the last part of the treatment, and the first days are more diagnostic. Then we do the metabolic therapy, and then we kind of finish up with the dendritic cell. If you want to just give a little bit of insight on that.
So the metabolic therapy, that is the first part of the treatment, is basically the core that is shared, all the mechanisms, the metabolic pathways of cancers that are shared no matter if it's breast, brain, colon, prostate. So we use a very similar therapy for all the patients because there are the metabolic pathways that cells will do to promote growth, to create new vessels to grow, etc. Of course, we can do some adjustments depending case by case. But the part where it's very personalized is the immunotherapy. Why? Because we take the blood from the patient, or in some cases, we can perform surgery to take a piece of tumor, a piece of lymph node, and we grab, in most of the cases of the patients with the blood, circulating tumor cells. That are cells that have detached from the primary tumor or the metastatic lesion and are flowing in the blood and have all this information that are called antigens. That is how our immune system can recognize that is a threat. So we grab all these pieces of antigens and we first we show to the dendritic cell that is the carrier, the one that is going to show to our immune system what they need to kill. And on the other part, we boost the immune system, we duplicate the number. So these are the soldiers that are going to learn how is the cancer, and they are going to be looking for them and create tumor lysis or tumor destruction. So it's a very personalized treatment. It's not, for example, a treatment for breast cancer. It's a treatment for a patient called Terry, for example.
Yes, exactly.
Yeah.
Exactly.
Yes.
All right, well explained. Every time you explain it, I understand a little better. To me, it's kind of like you piece of the tumor, you get the antigen, which basically explains as information on the tumor. You give it to the white blood cells, and it tells
the
them where
white-
to attack.
Yes.
So it looks for the antigen is kind of like the DNA, if you want to put it that way. Or is that a wrong way of
No,
explaining
the
it?
antigen is the marker,
The marker. The marker.
and so it actually puts a target on the tumor
Yeah.
that our immune system can see.
And sends the
And sends the-
lymphocytes and
It sends the specific type of T cells
The
or
T cells.
white cells
Mhm.
that attack tumors, and they're called natural killer cells.
All right. Thank you so much for your for joining us this evening. We had a very international audience. I want to thank Dr. Contreras and Dr. Larraga for today's webinar, and from Mexico with love from to you guys from all over the world. Thank you so much for joining us today.
Watch
Oh.
out with that sign.
Which one? Oh yeah,
Good.
I know. People get in trouble for that now. We're gonna give about 10 or 15 lucky attendees a signed copy of Dr. Contreras' book. You'll get an email if you are chosen, and just send us who you want to dedicate it to with your address, as long as it's in the continental US, because we have to ship to Singapore and it's very inexpensive. But thank you so much. And again, if you want to talk to Dr. Contreras, one of our doctors, please call us at 619-690-8450 or email us at info@oasisofhope.com or go to our website at www.oasisofhope.com and fill out one of our contact pages. Thank you very much.
Thank you
Thank
for
you.
mentioning.
God bless.